Hi everyone, and welcome to this lecture on smile design. My name is Dr Sam Jethwa. This is part of the Complete Dental course, and it is an incredible initiative. I've got to thank AJ Mehta, the organizer, who really single-handedly has thought this up, put it together for an insanely positive initiative. It's incredibly heartwarming to see a dentist put so much effort into helping others, and I'm happy and very privileged to play my part in this. I hope you've enjoyed the course so far, and I hope you enjoy my little bit of insight into my daily work involving smile design. Now, a little bit about myself. I am Dr. Sam Jethwa. I am an aesthetic dentist. I focus my practice on cosmetic dentistry, tooth wear, advanced cases, and we have a team at the practice that focuses on their own individual areas, and together we have a multidisciplinary team to deal with most situations. Aside from that, I am Director of Communications at the British Academy of Cosmetic Dentistry. The BACD has been the main reason why I'm able to do the dentistry that I love doing now, and has been a guide and a constant through my career. So if any cosmetic dentists or people interested in cosmetic dentistry are watching this, my absolute number one piece of advice would be join the academy and meet like-minded dentists who will guide through your career. Our practice is called Bespoke Smile. It's an advanced dentistry and academy, and we run courses there for dentists as well. Now let's talk a little bit about smile design, and specifically the power of smile design. What is it that smile design can do, and what does it actually mean? Now, when we talk about smile design, let's hear what it means to a patient, and this genuinely is demonstrating the power of what we as dentists can do.
I've got client bases in New York and in London. I work with women every single day who are self-conscious, who are, always nitpicking at themselves, and I do exactly the same thing. I've had issues with my teeth since I was 9 years old, and I've always had problems. It's always been a real insecurity of mine, and it just wasn't right. It made my face look wonky, it made my face look... People didn't see it, but I could see it, and it was something that I really wanted to get fixed and sorted. I actually got recommended by one of my clients, and I saw her come in. Her smile was just incredible. I was like, oh my God, your smile. So I've had these teeth done. It's actually brought out my inner confidence towards my clients, and they feel that I'm happier. They actually can sense the vibes off of me. When they used to throw me a compliment, oh my God, you look beautiful, your teeth are amazing, I actually accepted the compliment. Whereas before I'd be like, no, my teeth look like this, and oh God, no, I'm not pretty at all. But I can accept compliments a lot better now than I did before, which is a big thing for me because I could never accept it. But once you've had it done, then you realise just how worth it really was.
And that's one of my patients, Esther, who you can clearly see has got quite a striking smile now. That's the kind of look that she wanted, but it's made a huge difference to her life, and that is the power of cosmetic dentistry. So let's go back a step when we're talking about clinical side of things, and talk about how we're actually going to get there. What I'll cover today is a little bit about provisionals. Provisional restorations for me are the number one tool in my workflow that allows us to get the results that make the patients satisfied, gives the patients that individuality, allows me to really test and deliver a higher standard of indirect dentistry, allowing us to mold soft tissues, allowing us to have patients in a bite temporary phase, so we're testing the occlusion, allow patients to really get used to the emotional shock and impact of a big change that will occur when you have a smile makeover like this in a short appointment. So these things cause emotional stress, and the absolute number one thing we can do to help our patients through it and keep our patients on side is to develop provisionals that we have control over. and that is what I'll be covering a lot about today. The other thing I'll talk a little bit about is planning. Planning a case is really going to be where we can either make a success of it or whether we might fail in the outcome. And when we come to planning, I won't be able to today, unfortunately, because of time, discuss too much about the occlusion side of things. However, for me, that is always my number one starting point when we're actually planning the case, is looking at the bite and looking where the problems are and looking at how we're going to rectify those problems, and then ensuring that our aesthetics marry up with that as well. And sometimes we can plan a case and we can say, okay, we're going to improve the front 4 teeth, and that's absolutely fine. But the consequence of satisfying the functional needs of the case as well as the aesthetic needs of the case means that actually 4 teeth isn't going to be enough. We're going to need to treat more teeth. And sometimes we can, as dentists, we'll have patients' budgets and realistic factors to work with. And sometimes it's really important to be able to identify that, to be able to say, this is what actually is needed in order to fix the function to allow you to get the aesthetics. And if we don't actually do that, it's better off we wait until we're able to, in a position financially, let's say, to come back and do that. And in the meantime, let's protect the teeth in a certain way with another treatment, because I would rather you don't have just a compromised result and find that you're in a cycle then of restorative dentistry. So planning is really, really key. Let's have an example of that. So if we look at this case, this patient's got some wear on the lower anteriors. It's something we see quite a lot. A couple of chipped teeth up at the top and some composite. These were actually placed by an associate of mine just to build the bite up a little bit, just to give him something slightly more aesthetic and starting to test where his limits are in the bite. But if we look on the right hand side, he's got 2 implant crowns actually on the lower right 6 and 7 that are incredibly short, really small teeth. And this is a prime example of a dentist not planning the case effectively from a functional point of view. The patient had missing teeth. That's fine, we can accept that, but what has happened here is the missing teeth have just been replaced with implants without thinking about the teeth at the end. What we have here are 2 crowns that actually are barely teeth at all. So really what should have happened here is the bite should have been reorganized to allow an appropriately sized tooth to actually go on top of the implants, whereas we've just focused on getting the implants in and not really thought about the tooth. Another example of that is trying to do endo when we don't have a restorable tooth, and that's an example of not planning. So here, if this patient had come in, we would have looked at the bite, seen where the room in the bite was to give actually an appropriate clinical height, and then provided that to then allow the implants to be placed correctly. So really, this is just a small example of showing where planning allows us to have a better result, but also where provisionals could have helped, because we could have put that patient into a provisional bite, provisional design to test before we actually make the implant teeth to see if that is going to satisfy the functional needs. So let's move on a little bit to what cosmetic dentistry means to us in real life. Now we know that the biggest stress for us is the GDC or anything that could affect our registration, and of course without that we wouldn't be able to practice dentistry. So it is always a black cloud over us. We need to understand a little bit, and this is a reminder for myself and everyone of what the GDC says about cosmetic dentistry. You must remember that this is not a specialty. I'm not a specialist. I'm just a general practitioner who focuses on cosmetic dentistry. But cosmetic dentistry is not just for vanity. Sometimes, and most of the time, we have a functional element to it. So when we have that, it's important to understand where the regulators stand on these things. And we can see here that it's a trade-off between the retention of healthy tooth tissue and the fact that some cosmetic procedures require damage to healthy tooth tissue in order to be effective. What that's saying is, if you're going to do cosmetic dentistry, make it minimally invasive. Let's go into a little bit of detail about smile design and what smile design actually means. Now, my patients tend to come in and they will ask to see me, and then we'll sit in the chair and we will go through what they want. That's my first question. Why are you here? And they say, I want white, straight, even teeth, but I don't want them to look fake. And that is generally what I hear every single day from my consultations. So everybody's kind of after the same thing. But to get that, we really need to get inside the patient's mind. What is it that they think they mean when they say white, straight, even teeth? And I don't want them to look fake. Does fake mean we need uneven incisal edges or yellow teeth or cracked lines? Maybe they want to have it looking natural in that way. Maybe they just want it to look perfect but harmonious, which is natural in really what I think is what natural means. We don't need cracked lines, we don't need yellow teeth, we need nice, bright, appropriately coloured teeth that are in harmony with effects such as translucency and colour that really suits the patient and shapes that suit the patient to bring the best features of the face out. That is then looking natural. So really, when someone says anything like I want a white straight, well, how white? What is white when it comes to teeth? Straight, do they mean incisal edges? Do we mean actually the alignment of the teeth? Because if we're looking at alignment of teeth, we're definitely looking at some sort of orthodontics first, aren't we, before we look at anything else. And even, what does even mean? Does even mean straight in the sense of not crowded, or does it mean incisal edges? So we really have to break down these things, and what the patient might be meaning is something totally different. Prime example of that, patient say, oh, I've got an implant on a tooth, and what they mean is a post crown. Or they say I've got a cap on a tooth, and really they've got a filling. So there's certain things we need to break down when it comes to that. So when we want to find out, firstly, when we're talking about aesthetics, is how someone feels with regard to a natural or a false looking result. I'll always bring in certain celebrities and say, do you like Simon Cowell? Is that something you want? And then we start to really push that. And I really want patients to be honest with me, because I find that a lot of patients will sit in my consultation chair and they will say, oh no, I don't want that, and then we push it and we push it a little bit more, and it comes out that actually that is what they want, but they were just a little bit embarrassed to say, because perhaps they think we may judge. We will not judge. It's our job to facilitate and to advise in the right way, but we need to know where their goals are first. So that's the first element of when I'm thinking about smile design. But really, what are patients thinking when they're thinking about smile design? They're thinking about this. They're thinking about social media. They're thinking about photographs. They're thinking about feeling confident when they're smiling. And if we look at this photograph, that's one of my patients before and after. And what I think of it as, instead of smile design, I think we should start thinking of it as selfie design, because that is what patients care about. How are our teeth looking when we're looking at ourselves, like this on a Zoom call or in a selfie? So that is where I start to think about how my smile needs to look good. Can't just look good when we're looking at it from afar in a still image. It's got to look good in video, a selfie video, and that is where our aesthetics need to now be pushed up a level to where dentists were delivering aesthetic dentistry in the past. So if we look at the two main elements that will form the overall smile design, we're looking at aesthetic elements and we're looking at functional elements. Functional elements mean bite, tooth wear, missing teeth, consequences of that, spacing, tilting, really occlusal elements. And when we're doing indirect restorations, a lot of the dentists who come along to our courses say, the reason why I'm coming is because I don't feel confident placing indirect restorations in the same level of confidence that I have when I'm placing direct restorations. And when we probe that a little bit more, we realize that actually that's coming from a place of being able to fix a direct restoration relatively easily, but an indirect restoration of veneer, if that fractures or breaks or debonds and consistently debonds, that becomes a much higher stake situation for the patient and the dentist, and that's where the stress comes in. So we need to be able to deliver smile design and aesthetic cases with a strong functional element. If we look at the aesthetic side of things, we've touched on it as well already. We have the principles of smile design, which I'll touch on. We have a patient's wishes and individuality. Then we have what we know is going to look right. And we need to marry up those three things. We also need to consider who's actually going to be making these indirect restorations, and that's going to be our dental technician. Now, what is our dental technician thinking if we wrote on a lab docket, patient wants natural result? What does that mean? it really doesn't mean anything at all to the lab tech. So we need to marry up our goals for the smile, the aesthetic goals of the patient, and the vision of the technician into one vision that's shared by everyone. The way that I do that is I have a 3-step process. The first step would obviously be the preparation, the design. That has to be as minimal as possible. So when we come to our prep appointment, we should have our patients ready, either with aligned teeth, having had Invisalign or some pre-alignment possibly, or teeth that are in a situation that are healthy periodontally, endodontically, and we're ready to produce the most minimal possible result. Whenever I look at a patient, initially I will think about what our end result is, and I'll think about a treatment plan that gives them what they want and what we want to give them without biological cost, or as little as possible, and understanding then the consequence of that in the long term. So that's our first appointment. On that appointment, what I like to do is I create a trial smile that the patient will live with in real time, and I create that by hand using flowable composites, which allows the patient to have a bespoke design that is exactly what I think they need, with a little bit of their wishes involved, and I let them test that design. And that is then going to form our basis of our fit. Now, traditionally, what would happen in an indirect case is we would have a prep, and 2 weeks later we would have a fitting, and that's fine. However, the chances are that the look of the final result and the bite that's there, the functional element, has been slightly overlooked, because what we have is a guess. We have the technician's best guess based on, it is an educated guess, of course. They do have record, mold, photos, sometimes videos, bite records, and they will have some information. But what they create is essentially a best guess. And you speak to any technician and they will tell you that it is essentially them filling in the gaps for the dentist. And if we do that for our patients, then how are we going to be able to say to a patient confidently, yes, I can achieve your goals? Because we don't know really if we can. And that is why I'd say around 30 to 40% of my work is redoing existing treatment. And it's always down to 2 factors, the look or the function. So to identify those 2 things initially in a middle appointment, which we call the choices appointment, that will allow us to give our technicians a little bit more information and a blueprint design that they can then go and copy. So to summarize, we have our preparation and trial smile that's handmade. We then allow our patients to test that for function and aesthetics, and we bring the patients back to go through their choices, and by choices we mean individual elements that they wish to modify, or we will have a discussion about that. That choices visit, we're also discussing occlusion, and I'm seeing whether it's working or not, and then we go to the fit, which is a copy of our design. From a consent point of view, this is also very powerful because the patients know what they are getting. Let's look at a case to demonstrate this. Now, when I'm assessing this case, I'm thinking, where do I want the smile to go? We have a patient here whose concerns are relating to the fact that she's got dark margins around these crowns. All of them, bar the upper right one, have been there for about 30 years. The upper right one has been there for about 10 years. And they've all been done on the NHS when it was possible to do aesthetic dentistry, price per unit sort of treatment. Metal ceramic crowns, very classic, 6 units, and this was done a lot in that sort of time. Now, what's happened here is the gums have responded to actually the cement that is underneath. And if we scaled all of that area when we started this treatment, we found that it was cement, some zinc phosphate possibly, that has caused this recession. And so we didn't have teeth that have periodontal issues, other than minor inflammation caused by obviously the exposed margins and plaque traps and food traps. But otherwise we have a generally healthy mouth with some fluorosis, some lower in size of wear, probably as a result of slight constriction on the bite, but also the material of the upper crowns. And we've got narrow smile on the buccal corridors, where we've got teeth that are sort of set inward as well. Now, the patient's only real issue was that the darkness around the gum lines. But when we went through it further, we identified that actually widening the smile would be a benefit, and so we were starting to think about aesthetics with regard to the top 10 teeth. If we look at the case in a little more detail, we're assessing this using this photo to see how the buccal corridors are appearing and how wide they are, and we can see only 6 teeth upper are visible. We don't have any visibility of the premolars. We can also assess from this angle incisal edge position in the face. We can look at midline. Is there a slight cant? Is the nose slightly deviated? We can also see the asymmetry of the lip, and you can see on the lower right hand side of the patient there is the lip dropping down and the teeth going up, whereas on the lower left we've got incisal edges far closer to the lip. So we've got an asymmetry in the lip here, and these are important to identify at the start so we can set our expectations at the right level, and allows us to see where we need to improve the smile. If we are not getting these bits of information now and then producing a temporary that's going to satisfy them, then all we're doing is telling our technician, please lengthen right hand side. Well, how much? It's really a guess, and so we need to identify these at the beginning. If we look at the patient from this angle, we can see the reason why the buccal corridor on the right hand side looks narrow, and it's because the premolar on the upper right 5 is rotated, and we have the classic social six teeth that have been developed and built out with a thick restoration, and creating an increased narrowness of the smile and a dominance of the front 6 teeth. If we look further back, you can really see the buccal corridor issues. We can see how narrow the smile looks for the patient's face. We can also start to assess masseters and how wide we have the face on one side compared to the other. That will form part of my thought process of buccal corridors. How wide do I make it? Strong side of the face versus weak side of the face. And you can see the strong side is the right hand side, and that's actually at the moment the narrower side. So we need to develop this arch form far more than just looking at the 6 units. Let's go into a little more detail of the restorations then. So we used for this patient some veneers on the premolars to widen the smile, and we used obviously replacement crowns for the front teeth. This case was completed in Emax, and we're aiming to have our restorations as thin as possible to avoid preparation on the teeth. Now, if we look at the premolars, we're obviously widening them, so they're not thin, but that doesn't mean that they're heavy prep. They're going to be additive because we are widening the smile. So the important thing, there's slight confusion about thin, super thin, ultra thin. As far as I'm concerned, anything that's below 0.5 of a millimeter would be considered from the English language to be thin. Anything below 0.5 millimeter would be in the English language considered to be super thin. And so we don't need to get hung up on that as dentists. It's important for patients to understand that actually what that means is minimally invasive. But if you say to a patient on the back, I'll be placing thicker veneers, they might think that means preparing the teeth. So it's important to identify that actually veneers can be minimal if they are thin or they're thick, depending on the position of the tooth they're actually being placed on. Let's look at the planning of this case from an aesthetic point of view. This drawing just allows me to identify where I want to take this smile. So if we look at the lip position, we have an asymmetry on the lower right side. The lip drops down, and that's a muscle thing. That will stay there with the patient for the rest of her life. Upper lips tend to drop due to age and collagen in the face. However, on the lower, it's muscular. The lip is being pulled by muscles, and that's going to stay. So we need to think about what we're going to do on the right hand side to get that looking better and a bit more harmonious with the lips. Midline, I want to make that midline nice and straight, dead straight, ideally central, but if we can't shift that midline, then at least we should make it vertical. The other aspects I'm looking at is proportion. Do we think that the front teeth are in proportion with the rest of the smile? But if we look at it, I think the newest crown, the upper right one, is probably a little bit too big, a little bit too wide and bulky, whereas the upper left is less so. And so the upper left we used as our sort of guide to say that's kind of our template where we want it. We can then use the golden proportions of in golden ratio to allow us to design teeth that are in proportion going backwards from the upper left one backwards, but it really comes down to sometimes accepting the fact that the teeth are not all going to be the same size. They're all different. So how are we going to create illusions to make them look more symmetrical and harmonious and proportional to each other without physically having the size available that is exactly the same? Well, that comes down to looking at the gingiva to begin with. Now, if we're looking at the gingiva, we can see where we've lost the papilla in certain areas, and we've now got to think about, if we're designing the emergence of the teeth, are we going to make those teeth look wider? And the gum line is different on one side to another side, so we are going to find that certain widths of teeth will be very difficult to disguise to be symmetrical if we just accept the gum line where it is. And this is where, on most cases, I will use something like a soft tissue laser, or I'll be thinking about crown lengthening or contouring if the biological width is likely to be invaded. So we need to look at the soft tissue first. Moving on from that, I'll look at incisal edge, and I'll say, where do we want the incisal edges to be? And this can be assessed by asking the patient to do some talking, and we can see where the incisal edges are sitting. We can also take some photographs, as I mentioned, asking the patient to tilt down, and we can assess where the incisal edge position should be based on actually the opening between the upper and lower lip, and aiming for it to be just above halfway of that opening. And you can see at the moment actually the incisal edge position of the centrals is in a decent place according to this photograph. The other thing we need to think about is angulation. And you can see the long axis of the teeth that I've drawn on here is just to identify where we want that to be. And really we're aiming for a 5-degree taper towards the midline, always thinking about the belly button and how we want the teeth to be focusing down to the navel there. And that gives us around about a 5-degree. So what is that axis telling us? Well, it's telling us where we want the gingival zenith, so the highest point of the gum, to be. It's telling us how we want to develop our mesial embrasure shapes, and it's also telling us what kind of line angles and contours we need to develop on the surface of the veneer to actually create that nice axis that is going to look attractive. And then following on from that, we want to see how much to widen the smile. So I've added some drawings just to see how wide I want to take this smile. Now, if we're planning a case like this is just drawing lines using sort of DSD principles, drawing lines on teeth to make us focus on kind of where we want to take the smile, really helping us more than helping the patient. The other way of doing it is by eye, and we can draw using iPads or printing pictures and drawing things, and the more we do that, the more we're going to be able to see what needs to be improved on every smile that we look at. But this also helps if we're asking for wax-ups and designs. These sort of things can be sent to the lab technician, hopefully with a little more information than just a photograph. I'd want to actually ask the lab for maybe a wax-up based on an impression of a mock-up possibly in the mouth, using flowable composite, adding a little bit to make the incisal edges in the right place, so the technician's got something to work with. That's our end result for the patient. So we can see, if we move back, we've got our design and we've got our end result, keeping things very, very natural, and the gum lines have been modified slightly to allow us to actually create the line angles to be defined to stop that from looking false. And we can go through that here. The incisal edge is flowing with the lip, the axis is at a 5-degree taper, midline is at 90 degrees to the incisal edge, the golden proportions have been satisfied, and we've got line angles that accentuate that overall feminine design, and the gum line has helped us to do that as well. So overall, a success aesthetically. Functionally, the wear on the lower teeth still exists. Now, if we want to rectify that, there are various ways. We could build those teeth up with composite, allow the posterior teeth to dial in, and that's a very good technique if you're very, very good at doing that, and understand that process very, very well. Other option is obviously some indirect restorations. However, that is not ever going to be particularly minimal unless we're opening the patient's bite. So for the purpose of this lecture, let's just focus on the aesthetics at the top and how we manage to get those. That's the patient now completed, and you can see The buccal corridor, especially on the right hand side, has been developed. The lip asymmetry is no longer as obvious, and the proportions of the teeth are looking very, very natural. When I say natural, I mean harmonious with her face. I don't mean yellow and crooked. If we look at different angles, you can see a little bit closer that actually it's suiting her face quite nicely. And what allowed us to do that was provisionals. Let me talk a little bit briefly about symmetry. Now, these two faces are symmetrical faces. They have been computer generated to mimic one side to the other side, so they would be considered to be highly attractive faces. However, how many of us are symmetrical? Really, hardly anyone, nearly no one. And what we need to do is, like we've done in this case, is work with the asymmetries to actually create an effect of symmetry. So one side in this case is actually wider than the other side on the buccal corridors to make it look like it's less wide, if that makes sense. So really, when we're looking at symmetry, we need to be bending the rules a little bit and saying, okay, we have a face and we have the smile, but we need to be bending the rules away from that kind of perfect Hollywood, getting everything the same on the left and the right, because we need to work with the facial features. And when patients come in and they say, I don't want it to look fake, that is what I think they mean. They mean it's got to fit into the face. So if we look at that in a little more detail, this patient here, you can see on the left, has got relatively good teeth. They're just small, and she feels that they're not in proportion with her face, and the smile is a bit narrow, and I would agree with her. And we've given her some restorations here, no preparation additive porcelain veneers to her teeth, and what we've done is we've built the incisal edge down to actually give her teeth that are a little bit more proportional to her lower third of her face. And you can see that actually now in the after photo, she's got that support from the smile that really is lacking on the left. She's stretching to show that smile, she's trying to display it, and it's being hidden by the dominant facial features that she has. Whereas now we've got teeth and a smile that are working with that dominance, that are dominant in themselves, but just the right amount. So really, when we come to smile design, I feel that beauty is what it means to you. It's about being individual. It's not about sticking to a smile design formula that is the same for everyone. And with that in mind, I would like to declare that the Hollywood smile is dead. If someone comes in and they ask for a Hollywood smile, I try to break it down and I try to introduce understanding of why we want to have individuality in the smile for the patient till they understand what I mean. And that's when they can start to appreciate, yes, actually, you know what, that isn't what I want. What I want is a harmonious smile, and yes, we can make it look more perfect by choosing incisal edges of a certain shape and choosing porcelains of a specific opacity and things like that. But as far as I'm concerned, the perfect smile is dead. We're now looking at bespoke smiles, and the Hollywood smile is definitely died a death. So all of this comes down to individuality. Now, is there a science to it? Well, I don't particularly believe so. I think that if we look at this case, I think there are rules that help us to determine a smile design, but really what it comes down to is personal choice and individuality. Let's take this case. Golden proportion, for example. If we look at her top teeth, we've got long teeth, we've got an arch form that is narrow, we've got a dominant canine. If she wants an improvement, I've made a very rough mock-up here of just using flowable composite just to give us an indication of where we want to take the smile. So it gives us an idea of how we could make the front two teeth get swallowed up rather than be dominant by developing the arch, by moving the line angles, by working with the teeth beside it. We can see how we could develop the buccal corridors a little bit as well, and that's just a very rough mock-up. Now if we go to the final result, what we can see here is that actually the patient moved away from what we were thinking initially when she said, I want my front teeth to disappear. Well, actually living with it, she realised she didn't, because when you do that, the focus goes to the side teeth. and that wasn't something she was happy with. So when we came to the finals, what we did is we measured exactly where we wanted to take the centrals again, and we wanted to deliberately give the patient longer front teeth because that's what she felt suited her, and actually it did in the face. Unfortunately, I'm not able to show you face photos, but what we can see is that doing the mock-up first helped the patient to understand what she really did want and what she really didn't want, and it allowed me to veer slightly away from golden proportions but to give the patient a more bespoke result. So, is it a science? Well, I think that's debatable. Let's hear what a patient says.
Touch for designing each individual tooth and the way it should be aligned was really beautiful, even from the very beginning stages. Sam, to me, feels more like an artist than a dentist.
And for me to hear that from my patient was the biggest compliment, because that is really what I feel smile design is all about. It is artistry, using rules that are in existence, but now we're not sticking to them, we're now developing them to be more individual than they ever were. So really, it's not a science, it is an art, in my opinion. So, we've been talking a lot about modifying results to try to get them to be more bespoke for the patient. And this is where we come on to provisionals. How are we going to get those results specifically that much more individual than we were before? Well, that comes down to provisionals. Let's take this case. Very similar situation to the previous one I showed you. Her upper teeth are relatively good teeth. We have canines that she doesn't like how sharp they are. That's a common concern. And she doesn't like the dominance of the front two teeth. So we created a trial smile. This time the patient lived with this for a week as a minimum before coming back to discuss their thoughts. Now for this patient, her main concern was the dominance of the front two teeth. And by making the front two teeth disappear into the smile, we satisfied her initial concern. We widened the smile and gave her the incisal edges that suit the lower lip, that is asymmetrical. She came back and decided that she misses her front two teeth. So we decided to develop them slightly more, give that dominance slightly back into the final design, and develop this trial smile a little bit more to give her what she wanted again. And that is an art. We've bent the rules, we've gone slightly outside of golden proportion to give the patient a result that suits her. And that is an example of how much provisionals can help us once again. The other things that provisionals can tell us, well, it helps the patient to identify colour. We don't want to be presenting 5, 6, 7 different shade tabs to a patient. We want a patient to have a trial smile based on the colour potentially of other teeth, based on colour that we think is suitable, and then we want the patient to live with that so that they can then say, let's go up a shade or down a shade. And that's one way of doing it. I will tend to advise a patient based on my understanding of colour, reflection, texture, translucency, understanding of the material, understanding the skin tones in the eyes, what I think will be a suitable colour. Now remember that colour is not just the shade tab that we have, it's really breaking it down into slightly more complicated areas, but we don't have time for that right now, but the transitionals will give us an indication of the colour that we're wanting in the finals. Texture of teeth, incredibly important. Do we want to incorporate line angles that are defined or soft? Length of teeth, width of teeth, thickness, for example, how wide we can see on this patient, we've widened the buccal corridor. Phonetics, are we creating thick incisal edges that is going to cause some problems with S sounds or F sounds? And are we going to get to a point where that patient's muscles adapt to the phonetics? Maybe we do want that type of design, so we've got to give the patient time to phonetics to adapt, so that by the time we get to the finals, there's no shock factor when it comes to that. Midline, is the midline right? Have we got that canted midline corrected? Lip support. In this case, we have a thin lip, which is considering lip surgery, so we decided that actually we'd sort the teeth out first and see whether the surgery is needed. Sometimes thickness of the lip can be developed using a smile design, or it can sometimes actually create a more thin lip, so we do need to be aware of that. And if we have a temporary, then we're able to identify where we need to adjust the teeth to actually get the lip to sit in the right place. Facial aesthetics, of course, the rest of it with regard to how it sits into the face and occlusion. By testing the occlusion using diagnostic temporaries, we are able to be far more prescriptive to the lab of the kind of occlusion and incisal edge design that we want. Without that, it's just instructions and the technician's best guess using all the tools they have, but it is still an educated guess with fingers crossed that it's okay. So essentially, provisionals tell us everything. After we've designed our provisionals to be exactly what we want and what the patient wants, you can see on the left side of the screen my patient has got the transitional restorations, which I've hand designed using flowable composite. They've lived with that, they've approved that. And on the other side we've got the final restorations just seated to compare, and I will always do this to see if we're on the right track, and you can see there is very little difference. So our technician must understand how to copy our design. Rather than asking the technician to fix a lot of things from the temporaries, by fixing, then what happens there is that we end up with a different shape of tooth, and that gives the patient no indication of what we're going to get in the end. Another example, composite bonding done without consideration to the occlusion. Only a year ago starts chipping. Also insufficient thickness of material. Composite can't just be slapped on in 0.5 mil and polished. It's going to start becoming patchy and stain, and that's what's happened here. The patient is put into hand-designed flowable composite temporaries for 6 teeth, so 6 temporary veneers to develop the situation, and then we copy that into the final teeth as an exact copy of the trial. So if anyone watching this lecture is considering going into more of this sort of dentistry or cosmetic dentistry, it's a minefield. So where do we start? Well, I think initially building a portfolio is great. If we want to be working in practices that are producing these kind of results, or have associates, principals that are supportive in that, then developing a portfolio of results will definitely allow any potential employers to see the kind of things one can do. Remember that portfolios don't have to be perfect. They just need to demonstrate that there's improvement, or to demonstrate a willingness to learn and improve and do high quality, better work. And that's what any prospective dentist looking for an associate dentist to work in a practice doing cosmetic work will be more concerned about than CV, let's say. Photography, of course, we can't do any cosmetic dentistry without photography, and there's some incredibly good photography courses out there, and you can get a lot of guidance as to the type of photography. Mentors, well, mentoring is something that I'm incredibly passionate about. I would not have been able to be doing the kind of dentistry I do now if it wasn't for mentors that I've met on other courses and really contacted afterwards and connected with. And dentists are keen to help. Often after a course there'll be a support scheme, so dentists can still help the delegates to help with cases going forward. Maybe you're in a practice where you can rely on a principal to give you some support, but an association like the BACD will definitely have ability to mentor dentists. We have a mentoring link on the website where you can contact any of the board members for a mentorship, and so that is definitely something to consider, is looking at dentists doing the kind of work you want to do, attending their courses, allowing them to mentor, and really you will find a huge amount of information by having good support. Going it on your own is very difficult. We always need to rely on inspirational people around us who can give us really good, solid advice. Always remembering that it's one step at a time. I don't particularly feel I'm any longer in the young dentist category. However, people do still ask me, how did you do it so quickly? Well, actually, it hasn't been that quick. I qualified in 2012, so we're now coming up to 10 years. 10 years of constant learning and constant application of that learning, and it did not happen overnight. Things did take a long time to develop, despite that constant application and learning. It still takes a while. Hands-on courses are incredibly useful. Phantom head courses are great, and that's good. I don't know whether it's the best use of time to be able to be asked to prep a virgin tooth on a model for 3 hours in the afternoon. Is that a real life situation? I'm not sure. hands-on courses are very, very powerful with real patients. It's a difficult thing to organise, so there aren't many available, but it really does give you a real indication of actually the skills and the hand skills needed, and how every case is individual and not all the same. So hands-on courses highly, highly, highly recommended, especially for something like smile design. Even if you're not booking the place that does treatment, and you're coming to observe and assist, getting right up close with the patients and the dentist and watching the mistakes happen and then watching them being corrected, that is a real benefit there. So that brings me on to what we do, and we have the Bespoke Smile Advanced Dentistry and Academy, where we do develop dentist skills on hands-on courses every year. And we tend to sell out a year in advance, so we would like anyone who is interested to contact us as soon as possible to get that in the diary. We have very few numbers. Our 2 courses at the moment have 10 dentists, and the second course has 5 dentists, and that is the maximum to allow us to deliver the best possible teaching there. And this is coming from a practical, real life understanding of smile makeover, smile design and occlusion, and handmade trial smiles. Things that I feel that I've learned along the way from a lot of my mentors, from doing it day in, day out, and that is the kind of background of where the course comes from. At the moment we have the 6-day course, which is over 3 weekends, which is hands-on or assist observe, and it's a pretty intense course, but I would expect people to leave with a thorough understanding of everything we've been through today.
Is for dentists who want to take their dentistry to the next level. It's all about real-life practical workflows that give dentists the confidence to treat any case predictably. More than just smile makeovers and veneers, simplifying occlusion, hands-on, up-close, real patients, one-to-one mentoring, hand-sculpted artistry in trial smiles, knowing how to tackle a cosmetic case, a functional case, a full mouth rehab, and working with our lab techs to get the best results. This is what gives predictable dentistry. Watching our dentists develop and grow in confidence is really something I'm incredibly proud of.
And that brings me to the end of my presentation. So if you would like to contact with any questions, then please do contact me on Instagram. It's at Dr. Jethwa. I'll be more than happy to answer your questions. When it comes to anything about the courses, you may DM me as well, or you can contact us via our website, which is www.bespokesmileacademy.co.uk. I'll be more than happy to help. Once again, thank you, AJ, for allowing me to give this presentation and for inviting me to do so, and for allowing us to sponsor this incredible cause. And I hope you have all enjoyed the lecture and the complete dental course. So thank you very much, and wish you all well.